Tuberculosis.
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 This is information on tuberculosis.
Warning. Some images may be disturbing to some sensitive people.
Viewer discretion is advised.
TB was first discovered and named by the German physician Robert Koch in 1882. It was for a long time a difficult disease to diagnose and was easily confused with others. The cause of TB is Mycobacterium tuberculosis, which is a very small, rod-shaped bacteria. The bacillus can live in an oxygenated environment, making it aerobic. It divides every 16 to 20 hours, which is considered very slow in comparison to other bacteria, most of which divide every hour or less. Mycobacterium tuberculosis can survive in a dry state for many weeks and is resistant to weak disinfectants.
Most people thought it was a thing of the past, and yet we're hearing about it in the news all over again. How come is it coming back, or it never went away?
Tuberculosis never left us.
Tuberculosis is a global health problem. It is one of the most important, preventable causes of death and morbidity in the world today. In the United States, the disease continues to be a significant challenge due to immunosuppressive conditions, immigration, and non-compliance with testing and treatment protocols.
Another person just died. Where is your outrage?
No, I have no intention of murdering myself. I'm just putting myself in the back.
Dying. It's got a great beat.
Mycobacterium tuberculosis, MTB, is a slow-growing intracellular organism, which makes culturing the organism slow and unreliable. Latent tuberculosis infection, LTBI, occurs when people carry Mycobacteria bacilli in their body, but the organisms are dormant and still in small numbers. These mycobacteria are controlled by the body's immune system and are still in small numbers. In this state, the MTB do not cause disease or any TB symptoms. Individuals with LTBI are not infectious. They would be negative to most TB tests, including culture and smear microscopy. Small nodules are occasionally seen on chest X-ray. Until recently, the only test capable of identifying LTBI has been the tuberculin skin test, TST. The most commonly used TST is the MAN2 test. This involves an intradermal injection of purified protein derivative, PPD, into the arm. PPD is a mixture of proteins derived from dead M. tuberculosis cultures. An immune reaction occurs within 48 to 72 hours, at which time the induration is measured. This test requires 2 patient visits. In addition, the test requires up to 72 hours to get the result, and false positives can occur in BCG-vaccinated subjects or following infection with environmental mycobacteria. The DNA of Mycobacterium tuberculosis has a region of difference called RD1 that is not found in BCG and most environmental mycobacterium. The RD1 area of MTB encodes for 9 proteins, including ESAT6 and CFP10. These 2 proteins are used in the T-spot TB test to challenge T cells. If the T cells recognize these proteins, they secrete interferon gamma. The T-spot TB test is a simplified version of the enzyme-linked immunospot ELISpot assay technique. It identifies M. tuberculosis sensitized effector T cells activated by the presence of CFP10 and ESAT6 antigens from the RD1 region of MTB. Effector T cells are quite short-lived. Their continuing presence indicates the cellular immune response is currently encountering and fighting a pathogen somewhere in the body. Measuring the presence of effector T cells in a sample therefore diagnoses an ongoing infection. In contrast, the presence of memory T cells would only indicate that someone had been infected with a pathogen at some point in the past. Blood from the patient is centrifuged, and the number of peripheral blood mononuclear cells, PBMCs, are counted. The sample is diluted so that a standard number of PBMCs are added to each well. PBMCs are added to a pre-coated well that contains antibody to interferon gamma. Cells are incubated for 16 to 20 hours. In the presence of activated effector T cells, the TB-specific antigens ESAT6 and CFP10 stimulate the release of interferon gamma, which binds to antibodies to interferon gamma on the base of the well. Wells are washed, and a secondary antibody to interferon gamma is added. Following another incubation and washing step, the substrate is added. This produces spots on the well floor where the interferon gamma was secreted by T cells. These spots are enumerated to provide the test result. The T-spot methodology provides an effective means of identifying TB infection. The test is highly sensitive and reliable in targeted testing groups. T-spot TB provides comprehensive testing coverage for all high-risk groups, including healthcare workers, immunosuppressed individuals, TB contacts, and TB suspects. The assay detects interferon gamma produced by T cells in response to RD1 specific peptides, so the test is also very specific. T-spot TB test results are not associated with immunocompromised status. This is because the T-spot TB test requires a standard number of PBMCs to be used for every patient, thereby minimizing the effects of low cell counts. The T-spot TB test is highly specific, as it does not cross-react with the BCG vaccine and most common non-tuberculosis mycobacteria. Benefits of the T-spot TB test are its efficiency, requires one single blood sample, it is fast, next day results, and it is one and done, no second visit required to read test results.
Tuberculosis, TB, is an infection which you catch from other people. It's usually caught when other people cough up the germs and they then get breathed in and infect the lungs. Now, in the great majority of people who get infected with TB in this way, they don't progress to become ill at that stage. If the immune system is depressed in any way, they're more likely to progress to get active disease and become ill. The lungs are the commonest site to become ill. And the sort of symptoms that people get are a cough, which just won't go away, but particularly feeling tired, feeling run down, fevers, sweating particularly at night time, and losing weight. TB can spread from the lungs, either at the time of being first infected or at other times, to affect other organs, most commonly the lymph nodes. Often swollen glands in the neck are the result, and less commonly to other places like the brain, giving TB meningitis, the bones, particularly the spine, giving bony tuberculosis, and sometimes the kidneys and other organs. Tuberculosis is nothing like as common as it was before the introduction of effective anti-TB drugs in the early 1950s, but it's still a fairly common disease, particularly in our inner cities. Now, absolutely anybody can catch tuberculosis. It's generally the case that the healthier you are, the less likely you are to become ill with tuberculosis. Let's say that you actually get infected with the germs, you're much more likely to fight them off if you're in generally good health. Now, of course, there are some very specific things which may make you particularly at risk. For instance, HIV infections, diabetes, renal failure, and particularly being treated with anti-cancer drugs or being ill with some sorts of cancer can increase the risk of latent TB infection, making you ill with active TB. There are two main ways of preventing tuberculosis. BCG vaccine is a living, weakened form of the TB bacterium, and it's given to people so that it's strong enough to stimulate their immune system, so that when in the future they come across tuberculosis, they've got some resistance against it, but it's not so strong that it makes people ill. And it's about 70% effective in people with normal immunity. The other thing is an awareness of what the symptoms of TB are, because the quicker that someone is diagnosed with TB, the less likely they are to pass it on to other people. There's both bad news and good news about tuberculosis. The bad news is that if it's not treated, it's got about a 50% chance of killing you. The good news is bacteria don't respond to conventional antibiotics. You have to give special anti-TB antibiotics. So being on the lookout for tuberculosis and getting on the treatment, and crucially taking the treatment right the way through the course, which can be 6 months, sometimes longer, can give you a much better outcome than the pretty gloomy prospects that people had from tuberculosis in the past.
If the person has a positive skin test, a normal chest x-ray, and no additional symptoms, they probably only have a few TB germs, which means they're not contagious and in an inactive state. To prevent it from becoming an active infection, antibiotics should be administered. The antibiotic is called isoniazid, INH. After taking it for 6 to 12 months, it will keep the TB from becoming active in the future. If a person, on the other hand, has a positive skin test with an irregular chest x-ray and assorted symptoms mentioned earlier,
everything screams tuberculosis.
Not everything.
they have TB bacteria with active tuberculosis, which does make them contagious. They must be treated with a mixture of medicines as well as isoniazid. Complex and extensive treatment usually lasts many months, sometimes years. Successful treatment really depends on the cooperation of the patient. Failing to take the medicines prescribed is the main cause of unsuccessfully curing the TB infection. Surgery on the lungs of TB patients is relatively uncommon nowadays, because the medicine almost always cures it before such drastic action is needed.
You all react differently.